Okay, so welcome to the breakout session for CNS vasculitis and neurosarcoidosis. Once again, my name is Samira, and I'm a patient living with neuromyelitis optica spectrum disorder, as well as the founder and executive director of the Samira Foundation. So, at Seattle Patient Day today, on October 18th, we are so fortunate to have two wonderful local specialists with us to talk about and take a deeper dive into these diseases. So, if you don't mind, for our live and virtual audience, can you introduce yourself, both of you?
If you can't, I can.
How about now?
Yes.
Seems like now it's better. All right. So I'm Pavle Repovic. I'm a neurologist at Swedish Multiple Sclerosis Center here in Seattle, where I'm a director of the MS Center, and happy to be here today and to talk to you about these two rare conditions.
Thank you.
And I'm Gloria van Geldern. I'm a neuroimmunologist at the University of Washington, also here in Seattle.
Wonderful. So let's start with some basics, because I'm also learning about these conditions. So you guys can decide who wants to answer, but can someone tell me, what is CNS vasculitis?
Yeah, we can actually start with that, and you can perhaps get both of our perspectives on it. Since I think with a condition such as CNS vasculitis, because it's such a rare condition, you might get slightly different answers.
Okay.
But my understanding of the primary CNS vasculitis is that this is a disorder of the blood vessels in the brain. And specifically, it's an inflammation of those blood vessels that is present only in the brain and not outside of the central nervous system. So when we talk about CNS, central nervous system, we talk about vasculitis. That vasculitis in the central nervous system can sometimes be associated with other inflammation elsewhere in the body. So then it's not primary CNS vasculitis, but secondary CNS vasculitis from other diseases. But sometimes we have patients who have the same kind of inflammation in those blood vessels in the brain, and yet no inflammation anywhere else in the body, no matter how hard we look for it elsewhere. And those individuals are then diagnosed with primary CNS vasculitis.
Thank you. And Dr. Gloria, how about neurosarcoidosis?
So, sarcoidosis in general is a disease that affects lots of different parts of the body. It most commonly affects the lungs and lymph nodes in the area around the lungs, but it can affect the heart, it can affect the skin, and it can affect other places in the body. When we're talking about neurosarcoid, we are talking about those patients where sarcoid doesn't just affect those other parts of the body, but also the nervous system. Now that can affect the brain, so the central nervous system, the brain, or the spinal cord. It can also affect the peripheral nervous system, the nerve fibers in the arms and legs, the muscles, not as commonly. But so it is a disease that, unlike primary CNS vasculitis, typically affects other parts of the body as well, but neurosarcoid is when it affects the brain or other parts of the nervous system. And sometimes people already know they have sarcoid, and sometimes they don't. And the first person that diagnoses them with that is a neurologist, because the first place where it becomes visible or causes symptoms is maybe the brain, spinal cord, or some part of the nervous system.
When we talk about these rare diseases, how rare is CNS vasculitis? Can you kind of describe it in numbers?
Actually, I would have to look it up myself, to be honest with you. I would say it's extremely rare. I would say for this sort of a condition, we're talking about something that maybe on the order, I'm just going to put a number out there, maybe 1 in 100,000 or so, something maybe around I think it's somewhere closer to NMO incidence than MS. MS itself, multiple sclerosis, is 1 in 1,000. That's sort of the rough incidence out there. But primary CNS vasculitis is far less common. The big thing, or the biggest question for somebody who has primary CNS vasculitis, and for us who treat them, is whether we're dealing with a disease that will occur only once, or as a one-time problem, or something that will keep relapsing or recurring. And I think that obviously determines what kind of treatment approach we follow. And that, I hope you'll agree, Gloria, can be also the case with neurosarcoidosis.
Prevalence, incidence for neurosarcoidosis, do you know any numbers off the top of your head?
It's pretty similar probably to what Pavle just said for vasculitis, but I don't actually have the exact numbers in front of me right now either. And it's neurosarcoidosis is more rare than sarcoidosis. So in other words, not every patient who has sarcoid has the nervous system involved. But like I said earlier, oftentimes when you diagnose neurosarcoid, you don't even know yet that you have sarcoid in general. So it's definitely much more rare than multiple sclerosis.
And for both diseases, how about demographics? Does it affect men more than women or vice versa? Does it show up at a certain age or in certain parts of the world? Is it more common? Can you share anything about that?
Actually, because it is so rare, the typical profile, I would say, doesn't even exist. This is not a condition that primarily affects, in some conditions like NMO, you have this maybe 5 times or 9 times more common prevalence among women. That's not the case with CNS vasculitis. It's, I would say, not unique, not so distributed strongly across the genders or necessarily even ages. Typically, we see this in adult population, I would say. I would also say that I'm not a pediatric neurologist, so maybe this is my own bias. But what makes it so challenging, again, is the rarity of the condition, the different way of it presenting, and and the lack of really any approved therapies for it.
Oh, we're going to get to that. And how about for you?
I'll say absolutely the same is true for sarcoid. It can occur at any age, but probably more common in adults. And there is, unlike NMO or even to a lesser degree MS, not such a clear predominance of women over men. And it can be found worldwide. So it's been seen in people of different ethnicities and different racial backgrounds and has been found worldwide.
Let's talk about some common symptoms that these patients present with. When you meet neurosarcoidosis patients, like what is kind of the laundry list of symptoms you see?
And to be clear, not every patient who has neurosarcoid has all of those symptoms, of course. So typical presentations can be similar to NMO in that transverse myelitis or inflammation affecting the spinal cord. Maybe I should say, rather than calling it transverse myelitis. But so inflammation of the spinal cord is a common presentation. People with sarcoid can also present with inflammation that is around the ventricles that then leads to hydrocephalus, which is a condition where the spinal fluid that's in and around the brain doesn't flow properly, so it sort of gets stuck, and that can lead to problems because our skull is sort of limiting where the brain can go, and it can push on the brain and cause headaches or other dangerous symptoms. It can actually affect and that's a little bit harder to even figure out things like sodium levels or hormones, because it can affect the centers of those hormones inside the brain. But I could actually go on and talk about neurosarcoid symptoms, because one of the problems with neurosarcoid is it's the great mimicker. So if you are a trainee in medicine and somebody who is teaching you is asking, what could be the diagnosis in this case, and you say sarcoid, you're always right, because sarcoid can present as almost anything, and so that makes it really challenging to diagnose because it can look so very, very different from different patients.
Sure.
I would agree. and as Dr. von Geldern pointed out, sarcoid really is the great mimic, or by the way, the great mimic that used to be a label attributed to syphilis back in the day. Of course, now it's less common, so we don't talk about it so much. But it is neurosarcoidosis, and sarcoidosis in general is a disease that can affect different systems in different ways. Sometimes it can be self-limited with no intervention, which is also very strange for a condition that's inflammatory to just like pause on its own. But most of the time it doesn't, and it does require some kind of treatment to drive it into remission or pause. Sarcoidosis for us in the clinic, neurosarcoidosis, I would say, comes into focus when somebody presents with these neurological symptoms and we obtain an MRI. And on that MRI, there are some imaging features that can be characteristic or can clue us in that this is what we're dealing with, as opposed to MS, NMO, and a myriad other conditions.
What about some of the common symptoms for CNS vasculitis?
CNS vasculitis, by virtue of causing the inflammation in these smaller vessels, can lead to obstruction of those vessels and strokes. Mm-hmm. So that can be obviously a presenting symptom. The most common symptom of CNS vasculitis that's associated with it is actually headache, but that, of course, is not unique to this. It's a very common complaint. But I think the sort of telltale finding can be the presence, especially disseminated smaller strokes or signs of past strokes can be helpful. Yeah.
And depending on where those strokes happen to occur, it can lead to lots of different symptoms. So
yes.
Weakness, numbness, maybe even a Parkinsonian type picture, depending on where in the brain these blood vessels lead to small strokes.
And I meant to ask this earlier. For neurosarcoidosis, is it one of those conditions where it could be monophasic, but it also could be multiphasic?
Again, we're talking about rare conditions, so it's sometimes difficult to come to an agreement, but it can be monophasic. And I'm hesitating or smiling when you ask this, because monophasic in NMO or in MS is usually a pretty brief thing, whereas in sarcoid, it can be a one-time thing, but it tends to be a little bit longer. So people might need a longer time to improve from their initial attack, so to speak, of sarcoid than maybe from some of these other conditions that we're dealing with here today. But yes, it can sometimes be just a one area or one time of inflammation.
So now let's switch gears to diagnostics. For CNS vasculitis, so you mentioned that you would do an MRI, but are there labs that you would do? Are there specific biomarkers for the disorder? Do you do a spinal tap? Like, what does the workup look like?
So the typical workup will start with obviously immediate workup in the emergency room if they present with a stroke, and maybe something going down that path initially. But then ultimately this MRI will bring up the possibility of something more than a stroke, something maybe recurrent and or more widespread. And what I mean by this is that, especially when a younger person presents with multiple vascular insults, you always think, why is this happening to them? This really shouldn't be happening to somebody of that age group. And so then you sort of start digging, and then obviously you run a number of blood tests to try and identify the culprit, but they typically come back unrevealing, right? So the typical markers of inflammation that are associated with vasculitis elsewhere in the body can be in fact normal in the primary CNS vasculitis. They can be slightly elevated, but really most of the time they're actually not diagnostic. We do a spinal tap usually as the next step of testing, and there you might find signs of inflammation in the form of elevated number of white blood cells in the spinal fluid, and maybe a few other markers, maybe protein is elevated, but you might not find the quote-unquote smoking gun of any particular test that says, ta-da, this is the disease. Instead, what people will often then do if they suspect CNS vasculitis or vasculitis in general is there's this actually fairly long workup for, again, peripheral inflammation or markers of systemic rheumatological disorders, which you sort of embark on. And in parallel, you're starting to search for signs of actual vasculitis. So you can be imaging the vasculature in the brain. You can do that in different ways using magnetic resonance or CT angiography. So you're trying to image the blood vessels using these MRI or CT-based techniques. But very often the affected blood vessels in CNS vasculitis are too small to be visualized with just these techniques. If you want to think about it, it's almost like you're looking for you're looking for a traffic pattern disruption in Seattle, and the problem is on 45th Street, but you can only see what's happening on the interstates and highways. You don't have the detail to see what's happening on those smaller surface roads. So you sometimes have to go one step further and try to image this using more invasive techniques of angiography, where a catheter is advanced through the groin, and then you inject this dye and you image this under X-rays to see just as much of those small streets as you possibly can. And even then you can miss it, right? So the most definitive test for primary CNS vasculitis is actually a biopsy, and where you literally take a chunk of brain and the brain covering and examine it under the microscope to see where are those blood vessels, because they look like tubes, and is there inflammatory cells around them, which you can imagine. You've got this whole city of Seattle, and there are some issues with some of the streets, but not all of the streets, and they're mostly small streets, and you're taking your best bet to pick a tiny chunk that will tell you what's happening. So you could be wrong. You could actually miss the part of the brain where this diagnostic process is happening, and you might just find normal streets there and no inflammation, and it could be a non-diagnostic biopsy. So that's one of our biggest concerns when we go down this path, is that we go through this whole big old process and we come up empty-handed. So that can be super frustrating for patients and for their clinicians.
Thank you. How about for neurosarcoidosis? What does a typical workup look like?
So if you think about sarcoid, which you always should, because almost anything can in fact be sarcoid. But if you think, oh, maybe we're dealing with sarcoid because of some symptoms and then often some MRI. On the MRI, you would typically expect to find inflammation, which you also find in other diseases like NMO. Then you have to figure out, could this be NMO, could this be sarcoid, could this be MS, could this be something else? And you would check for some of those other diseases. We have aquaporin 4 for NMO, so we need to check that and make sure it's maybe not NMO. You're checking for MOGAD, so you're checking for MOG antibodies. So you're checking for some of these things where we think we now have antibodies. And if you don't find that and you're still wondering, we could be dealing with sarcoid, then you're often trying to look broader than the nervous system to the rest of the body to see if you can find signs of it somewhere else in the body, even if the patient had never symptoms of sarcoid somewhere else in the body. So let's say they've presented with inflammation of the spinal cord, but now you're hunting for sarcoid, and so you often would do take a picture of a big part of the body with a test called a CT PET scan. So a PET scan is a test where you're injecting certain markers that will be taken up by active cells in the body, and they can be active because of inflammation, like in sarcoid. They can also actually be, this test can also be used for finding cancer cells, because cancer cells are active as well. And so you do a picture basically of almost the entire body, the lungs and the belly and everything, to see, is there somewhere else in the body some hidden inflammation that might be easier to get to than the brain. And so you're trying to ideally, in the end, often confirm this diagnosis of sarcoid with a biopsy. Said this earlier, the hard thing about both CNS vasculitis and sarcoid is that you can only really be sure, and even that is challenging, like Pavle described, because you need to find the right piece to biopsy. But you can only really be sure that you're dealing with this disease if you can look under the microscope and find it. So you're doing this PET scan, this PET CT scan, to find an area where you can maybe biopsy a lymph node, or maybe get some sample from lung tissue, either with there's different techniques to doing that. So you're trying to find a piece of tissue that you can look under the microscope for sarcoid for. Sarcoid is a very interesting disease. It's also an inflammatory disease, like all these diseases that we're discussing today, but it has a unique finding on the under the microscope on tissue, and those are so-called granulomas. So these are like little rings or little clusters of immune cells in a very typical way. So when you find these granulomas, you know that you're dealing with sarcoid. Sometimes you don't find a place elsewhere in the body that you can easily get a piece of tissue from, and you might need to see if you can do a biopsy of the brain and the covering of the brain, or sometimes you just need to rule out a lot of other things and say, well, we think this is probably sarcoid, but we can't prove it.
That's called differential diagnosis when you go down the list. Okay. So a patient is suspected to have CNS vasculitis or neurosarcoidosis. What is the acute treatment, and are there long-term preventative treatments, even if they're not approved for either of these disorders? Maybe we'll start with you with CNS.
This is actually something I wanted to add a comment to while we were still talking about the diagnosis, that directly ties into this question you just asked, which is that we're going through this big old workup, right? Where we're starting in the ER with one imaging, then another imaging, then another imaging, then a spinal tap, then more blood tests, and the clock is ticking, because the more we're thinking that the patient might have neurosarcoidosis or primary CNS vasculitis, and let me just tell you, it's usually not just those two possibilities, and the more we're honing in on this is probably inflammatory, the more there is a pressure to start treatment such as high-dose steroids. And yet, if we do that, the inflammation can improve, those cells can melt away, and your ability to find them on the ultimate test may be lost. So you may, by treating too early, you may help the patient get better that time, but you may lose the opportunity to tell them what they have. It's a very hard trade-off to navigate in the clinic, in the hospital. You know, you don't want to withhold treatment that might work, but if you use it too soon, you will maybe never know exactly what you're treating. And we're talking about drugs that have significant side effects that they might be on for months or years, and you're like, do I really know that you need this? Do I know what I'm treating? As a physician, I will tell you one of the most disconcerting things is treating people without knowing what they have. Because you don't know if all of the side effects and risks and potential harms of this therapy are even justified. And as you told us earlier in the introductory talk, with your own journey, going through multiple therapies and not having a biological test or proof of what you have, I mean, it just really takes a lot of conviction on the part of your physicians to sort of believe that, yes, this is what my patient has, and yes, we do need to do this next step. And I would like to think that when this happens to me and my patients, that I always go back to the drawing board and review, what did we do? Did we miss something? Can we think of something else? Could this be something we haven't considered yet? Right? So when people break through, especially when they break through the therapy that we start them on, your first question should be, is this even what I thought it was? Mm-hmm. All of us today can tell you stories where things got missed, when we thought we had treated something, but it turned out to be something else. Mm-hmm. That doesn't mean we're bad doctors, but sometimes these presentations can be very, very challenging to discern, and you may be completely on the wrong path. One of the biggest concerns that we have is that it could be a lymphoma, it could be a tumor, it might not even be inflammation, right? Because all of those things will also respond to steroids, but then they come back and you're like, was I even in the right neighborhood of things? Mm-hmm. So that's where having a logical sort of algorithm that you follow through, and then having colleagues off of whom you can maybe bounce some of these more challenging cases and see, well, what do you think this could be? Am I missing something? Is crucial. Because we're all human. We can all miss something or misinterpret something. And
Can I just real quick add to that? Because I think you're absolutely right. And it's not just because something got missed, but sometimes things don't declare themselves until later. And I just described sarcoidosis and how you're looking and you're thinking, could this be an MO? And you're checking for antibodies. But as we all know, some people have seronegative NMO, or sometimes you don't see the antibodies when you first see the patient because maybe they already got steroids in the ER before anybody ever did anything else. And so you might have to repeat that and recheck that, and it's very, very important to keep an open mind and keep wondering, am I missing something, or is there another explanation for this?
Wow. And then what about acute and long-term treatments for neurosarcoidosis?
So the main juice of neuroimmunologists is steroids. That's probably true for all of the conditions that are discussed on this day here today. And so that's true for sarcoid too. We typically in the acute setting start with steroids, and unlike some other diseases like MS or some other diseases, you often need to give steroids for a little bit of a longer time. So when I'm saying in the acute setting, it's often not just for a few days, but tends to be maybe a little bit of a longer process, maybe weeks or months potentially even. And that's where then some of the other medications that we use for sarcoid come in, is that when we feel that the disease doesn't really stop being, that the inflammation doesn't really stop with steroids, and we're worried about side effects of steroids in the long run. We're trying to get in some additional medications that affect the immune system to avoid having to give steroids for too long or too high of a dose. So sometimes that's called steroid-sparing medications. And rheumatologists do that a lot with a lot of their conditions. And sarcoid is similar in that it's often a bit of a, while you're going down on the steroids, you might need to give a patient some other medication, and those are often borrowed from the world of rheumatology. So methotrexate, infliximab, which is an infusion, those are often medications that we can give to spare patients having to be on steroids for a long time because they have a lot of side effects.
Yes, us patients refer to steroids as Satan's Tic Tacs. So I know it all too well. You know, I have to share some commentary here. So I have NMO, and as I shared earlier, when I got diagnosed with NMO in 2014, my disease was a very different story. I mean, it was literally like a death sentence. There was a time where the doctors were preparing my parents for potentially the worst. And we didn't have the therapies. Thank goodness we had the aquaporin 4 biomarker available that Professor Lennon discovered in 2004. But even so, there were so many patients who were, you know, testing negative like myself. And I am like having PTSD myself, listening to both of these wonderful doctors and the kind of responses that I'm hearing, because it takes me back to 2014 when things were really scary and bleak for patients like myself. I have goosebumps on my arms. You can't see them. But the thing that's also so fascinating is that 11 years later, at this event where we have 6, 7 disorders kind of mixed together, NMO is, as all of us have been saying, the poster child for these rare demyelinating conditions. In a decade, we have made so much progress with the testing, the imaging, the therapies that are available, the amount of researchers who are involved now in NMO and the clinical trials and the therapies. I mean, the list goes on. So like, my hope in sitting here and listening, and then of course looking at the patients, is like, what can we learn from NMO and apply to CNS vasculitis and neurosarcoidosis? And is there anything that someone like me or the foundation can do to really accelerate things for these patients? Because I'm feeling very sorry for them right now.
Well, I think you hit the nail on the head when you mentioned the discovery of the aquaporin 4 antibody. All these diseases, they all are driven by biological processes that we don't fully understand. Understanding the biology of primary CNS vasculitis and neurosarcoidosis holds the key to treating and understanding and diagnosing these diseases better. So once we are, I would say that as a field of neuroimmunology in general, that discovery of the aquaporin 4 and some of the other antibodies maybe before that in slightly different settings, those were the watershed moments when we moved from, you know, let's call it 20th century medicine and before, which was largely based on syndromes and presentations and these descriptions, to a 21st century medicine that's more anchored in biology, where these actual molecular processes are explaining what we see on the outside. So we talk a lot about this in medicine, we call it phenotypes, like what you see, what the patient tells you, what they experience. And that's on the outside, right? But what happens on a microscopic level? We keep trying to get at it from different angles, and we still haven't gotten that, you know, that key to what drives this. If and when we do find the key, that then tells you, oh, it's driven by this antibody. Through these processes, let's target the complement. Let's target the B cells. Let's target where these antibodies come from. And that then leads to, trials and therapies that work. Our secret sauce has been steroids, because steroid is fairly broad anti-inflammatory, right? And it kind of covers many bases, but, it has a lot of other targets in the body and side effects, and is not, necessarily a cure. So it's a very shotgun approach in a way. And we would really like to know what went wrong biologically and how can we counter that.
So just a follow-up question. Are there researchers and scientists working to find a biomarker, an antibody for CNS vasculitis?
I'd like to say yes, but if you ask me who they are, I don't know off the top of my head, I'll be honest.
I got to find them. I'm going to find them. Okay. And the same question for you, for neurosarcoidosis.
So yes, there is research in neurosarcoidosis, but obviously a lot more is needed. And I agree with what Pavle just said for vasculitis, is that it would be extremely helpful to not have to do these. I mean, I mentioned steroids, I mentioned methotrexate. Those are pretty broad medications that are great. They've been around for a long time. But if you could find more targeted treatments, I think that would be a huge step forward. And I described earlier that we know on a pathological level that we see these granuloma, but we don't always know what has triggered that and what has caused that. So getting deeper into the biology, getting deeper into our understanding of these processes would enable us to have hopefully more targeted treatment approaches. And one challenge, I think, for sarcoid is that a lot of different specialists are involved. We've talked about the neurologic perspective, but there's pulmonologists, lung doctors involved. There is a rheumatologist. There is other specialists, cardiologists, and so forth involved. And bringing together the pulmonologist in particular and the neurologist in doing research and in helping us understand this better, I think is crucial, because sarcoid treatment, neurosarcoid treatment is probably not going to be unique to a sarcoid treatment in general. So if we can get better treatment for sarcoid overall, that will help neurosarcoid too.
I have one more question, and before we open it up to the Q&A, and I want to end my session with these doctors on a positive note. What, if any, breakthroughs have there been with either of these conditions? No.
All right, we want to end on a positive note. I think maybe for sarcoid, I think maybe one key. It's not as maybe exciting of a breakthrough as the big year of NMO with all the medications that were approved. But I do think that it's been important over the last maybe 10 years or 15 years or longer, that it's been more on people's minds, that people are even thinking about it. And I think that is different from 40 years ago.
That is good news.
I would maybe also add that in the field of neurosarcoidosis, there is a welcome recognition of the benefit from the biologics therapy earlier on, which is a little more targeted. So I would say, but although that's not a particularly recent development, it's still a welcome one. I am racking my brain to come up with a comparable advance in the primary CNS vasculitis, but I just can't make one up. I think our treatment algorithm for this condition hasn't changed all that much in the last 15 years since I entered the field of neurology. And so we need we need the Sumaira Foundation for PCNS
Yeah.
vasculitis.
Well, that's kind of why.
To drive this.
Yeah, so to our patients in the audience and on our virtual audience, that's kind of why we decided to include CNS vasculitis and neurosarcoidosis, because we got the sense at the foundation that like these diseases are where we were a decade ago, and we've also
or
or 2 decades ago. Yeah, exactly. And you know, mobilizing all the different stakeholders and making noise and coming together like days like today, who knows if this is going to like scratch at the surface even a little bit to inch us closer. So like if there is anything we can do in addition to including these patients and these doctors in our patient days, we would love to help, because like I now can't sleep at night knowing that these patients are just kind of in like, you know, limbo, or it's scaring me, actually. I'm a deep empath, so I feel things really, really deeply. And I'll be totally honest with you, the first time I heard about either of these disorders was when we were in Salt Lake City with Stacey Clardy, and she was like, I think we should invite these people. And I was like, sure, the more the merrier, join the party. And then I started hearing these stories, and then hearing from the doctors and doing some more research, and then coming here and talking to Shufro and you guys, and I'm like, whoa, this is scary. Like, we need to be doing more, all of us. And I know you guys are working really hard, but like, I think we need to make some noise.
Agreed.
Yes.
Okay. Well, I would love to open it up to questions to the audience, if anyone has any. It will be totally anonymous, so you won't be seen on camera, but...
Thank you very much for the presentation and the information. A couple questions. CNS vasculitis, what is a prognosis? Like what's to come? And have you seen it ever morph into, they are watching me to see if it's going to morph into a lymphoma. Has CNS vasculitis ever morphed into these other conditions, the MOGAD and MSOD? I totally hacked the acronym.
It's still a mouthful for all of us.
So prognosis, and have you ever seen it morph into X, Y, and Z?
So the second question is a little easier to answer. No, I usually have not seen it, unless, as we mentioned earlier, when the patients are still not diagnosed and we think it's something, but we're not sure. And then it turns out that it is a lymphoma. So there are particularly difficult forms of lymphoma, perivascular lymphoma, or lymphangiomatous, that's also a mouthful, that can present like that. So there are situations where it's not it was never vasculitis, it was always a lymphoma, but we thought it was vasculitis. So it doesn't quite morph into it, right? It is what it is. Now the outcomes and the prognosis are frankly a question mark. To a newly diagnosed patient, we say, here, we'll do the best we can and, treat you with the steroids. And like if the steroids don't work out, or people are breaking through, we will even reach for what we consider to be heavy guns, like things like cyclophosphamide, sort of chemotherapy type of agent, to try and arrest this process. But the hope is that it doesn't recur. The fear is that it might recur, right? And we don't yet have a tool to tell us who will and who won't recur. So we follow this usually with a longer taper with steroids and cross our fingers and hope that that's all this is. So that's why the answer to your first question is a little more complex as far as the prognosis. But one thing we can tell these people is that they will never have NMOSD, because that's sort of lightning striking twice. I mean, who knows, now that this is getting recorded and going online, somebody is going to show up. Never say never. But the odds would be exceptionally low.
Thank you.
Any other questions from the audience?
Hi, thanks again for your presentation. I was recently diagnosed with sarcoids, and I'm just curious with two things. I'm very dependent upon infusion treatments, which I'm thankful for, but I'm just curious if there are any future things coming down the lane that will involve me hopefully taking those same types of treatments, but at home maybe, with like a pen, no pills, but something like that. And then my second question is, I'm partially blind, so I'm dealing with something that's like an invisible disability. So I'm just curious, how do I navigate that type of world dealing with that whole new thing?
So those are two important and separate questions. Let me maybe start with the first one of the treatment. So in general, there is several different ways to treating neurosarcoid, and often infusions, if infusion treatment is the right option, depending on the infusion, can actually be done at home. And I'm saying often, not always. Depends on insurance. It depends on lots of different factors. And then there's some treatments that can be done as injections or small infusions that are given in the skin, in subcutaneous tissue, and that's also not always requiring going to an infusion center. So I think it's good to bring that up, to say, okay, this is helping and this is great, but this is also challenging, and I have to go to an infusion center and I have to spend a lot of time and energy and money to go get these treatments, to discuss with your doctor and with your provider, what does the reality of this look like in the long run? If this is just for a short time, maybe this is doable, but what other ways of getting my medications could there be in the long run? And now the second question of the invisible disabilities is an important one, because I think a lot of people here, whether they have sarcoid or NMO or any of these conditions, is dealing with that. Even an MS patient is dealing with that. And I think that's really, you're right, that's really challenging. And I think it's up to us as providers and you as patients to talk about it and to tell the people in your world and around you about it. I'll tell this story, even though it's an MS story, because I think it's kind of cool. I heard that I think it's Ireland, they actually put together a pub that was trying to show people that don't have MS what it's like to have this disease. And it looks like a normal pub, but you walk in there and everything is a little bit off. The floor is a little bit tilted, so you're a little bit off balance. The menu on the wall is written in a way that's a little bit blurry. So on the surface, you don't see that something is wrong, but then when you're trying to live your life or when you're trying to go into this pub, things are a little bit off kilter. And so I think it's important to tell these stories because you might not notice that you can't see. You look great, and I don't see that you have trouble seeing. People might not notice that somebody has problems with their bladder, or that they're fatigued, or that they have any of these other symptoms that you don't see. That disability is more than being in a wheelchair. That symptoms can be invisible, especially when a lot of these conditions are in younger people. So there's no easy answer to how to deal with this, other than, I think, being open and talking and telling the people around you. And that's true for the patients. That's also a bit our job, that we tell the world that this is what it looks like. And I think that's true for a lot of neurologic diseases in general, that people don't think about it unless they know somebody that is dealing with it.
I would just like to add one other thing to what Gloria just said. I think for people in your immediate surrounding, your family, your co-workers, or people you are close to, speaking is the best way for them to know. At workplace, this can be a little tricky, so that's why speaking with maybe a vocational counselor, if one exists, or if not, you can reach out to any of us and we can connect you to one. How do you approach your employer and tell them that you can still do the work, but you just might need a larger screen or brighter screen or quieter environment or whatever. So these are called workplace accommodations, and most employers will accommodate that within reason, and because they want to keep you working, and our patients want to work and be productive. And so there are ways to do this without telling them necessarily your entire health history. So there's that. However, there's also these situations when you go to a Mariners game or a place where There's just too many people, and you can't tell them all what's going on. And I have a patient, or actually several, who in those crowded public spaces will intentionally bring a fold-out cane or two and just put it out there and be like, get out of my way, because I can't just explain to all of you that I'm not exactly steady. But if they see you, most people will give you a little bit of space. Now, many of my patients also have fear of appearing with a cane, so I recognize there's a resistance to that. But when it's this situation where like you just cannot explain to enough people all around you who you don't even know what might be your limitation, sometimes a prop like this, an aid like this, can project that, yeah, I do need a little more space, I do need a little more time. Otherwise, everybody just expects you, to just fly out of the train or bus or wherever it is that you are and move at the speed of everybody else. It's our bias as a society that we just assume that everyone can do what we can.
And I can just conclude on the note from a patient perspective, because I also live with invisible illness now. I think in the first few years of my life, it was very clear that something was going on with me, and, people kind of figured it out. And now, I'm in remission, but, I still have bladder issues that I haven't managed. I have neuropathic pain. I have a 40% visual field deficit, so I also have vision loss. And so living with an invisible disease is both a blessing and a curse. It's a blessing because, okay, it's great. I don't look like I'm sick, or it's not obvious to the naked eye that something is going on or that I'm struggling with something. But it's also a curse because you are struggling with something. You are suffering the consequences of your illness. And sometimes people may not believe it, or they may not understand it because it's not so obvious to them. So I understand the frustration of both. I will tell you what I did for myself as both something to help me, but also something to protect me, was I live in the state of Massachusetts, and with the help of my doctors, I was able to get a transportation access pass. So this is for people who need, it's like the handicap sign is on it. So I get very discounted train rides. I board first on the plane. Some people will look at me when I'm boarding first and like roll their eyes, or what. Even some of the people working in the, at the airport will be like, sorry, what? I'm like, first of all, it's illegal to ask. Here is my access pass. I have it thing. But there are ways to accommodate and help in addition to, what Dr. Pavle also suggested. So we can always talk offline, but if you ever want to bond over something like this, I'd be happy to. But anyway, thank you so much for this very informative panel. I learned a lot, and I think the biggest takeaway from me is that we have work to do in this space. I feel really good about where NMO is, right? Of course, there's always room for improvement. I think our trial is going to answer a lot of questions. I feel good about MOGAD. We've got clinical trials. They've identified, or the test became commercially available in 2017. AE has some things in the work. SPS has some things in the work. But of all the disease states that we are covering and included today, these two need the most attention. So this might be my new special project.
Let's talk more.
Yes, but thank you both so much. And maybe we can give them a round of applause.